So what I'm hoping to provide today in this session is some tools that you can come away with to just have more knowledge about some approaches, particularly for older adults, and also how to approach this in the skilled nursing facility setting, and some tools you can use to answer the questions that are coming into all primary care providers right now from patients, from their loved ones, from their caregivers, from home health agencies. So I'm going to turn it over to Dr. Ong. Dr. Ong is always a panelist on our Project Echo Geriatrics sessions. He's a fantastic geriatrician and internist based at Harborview Medical Center in Seattle, as am I, also at Harborview. He's also the medical director of the post-acute care service. And in that role, he's really been at the forefront of planning for what's coming and also planning for what's already happening in skilled nursing facilities with COVID cases. And I will let him talk about it, but he's done a really fantastic job getting the skilled nursing facilities ready for COVID. So I'm going to turn it over to you, Dr. Ong, if you wanted to share your screen. I know you have some slides.
Great. I promised everyone that that was not a COVID cough because I was tested and it is negative. So let me see if I can make this happen. Let's see. Can everyone see that in front of them?
We can see Zoom screen.
Awesome. All right, let's see this. How about now?
Yep.
All right. Perfect. Can you see UW COVID response in front of you?
Yes.
Perfect. Well, that went much better than I thought. And so, like what Dr. Bennett was talking about, all our lives have completely been upended because of this, essentially, and our loved ones as well. And so the reason why I got involved with this is that one of the earliest places that we have recognized that there is a high propensity of these cases and also a very high mortality rate and high risk as well is within these congregate settings, particularly with the nursing homes. And so what we had to do very, very rapidly was develop a response to stand up the local community and to stand up our nursing homes and the people who live in them and also the people who work in them as well. We were trying to circumvent and prevent what we saw at Life Care in Kirkland. And so what I'm about to present to you is a work in progress. And so when I say that we are literally building this as we fly, that truly is the case. And so one of the first things that I will share with you is that a lot of the work that the University of Washington has done around COVID is public information. And so what I would encourage you to do is that to look at this website, and there's a lot of policies, there's a lot of workflows, there's a lot of algorithms, testing criteria. Everything I'm about to present to you is on that website and then some more. And so if you are in an institution that you need this support, please, you don't have to reinvent the wheel from the very beginning. It is there and readily available, okay? And this will appear also at the very end as well. And so when we developed our response in terms of standing up this very high risk community, what we wanted to do was to decrease the spread of the communicable disease as a public health service. What we also wanted to do was to decrease the acute, the burden on the acute care hospital system, the area clinics, and also the EMS services. What we saw at Life Care was that because of their proximity to Evergreen Hospital, they overwhelmed that system quite dramatically, where their intensive care beds were full and their emergency rooms were inundated with not only patients, but also employees and staff from Life Care as well, that they trickled down to other hospitals within the area, such as Overlake, if you know your geographic region, and eventually down to other hospitals as well, down into the central part of King County. What we wanted to do also was to show a commitment to our community partners and to our community. We have a network of nursing homes that are a part of our contracted facilities, and we wanted to serve as a model of care. I just jumped off a call right now with various different health systems, with also the King County Public Health and the Northwest Health Response Network. We'll talk about what that means in a little bit, but there are multiple different health systems that are trying to stand up our local community and to stick together in this, so that we are truly not practicing in a siloed fashion, but we are trying to respond to this as one singular unit. And we know that we are very much an integrated system at this point, where not only are the masks made in China, but for example, the things that happen within a nursing home has a huge impact upon the acute care system as well. And so we are very much interconnected. And so we developed our intervention into 3 different phases. There's an initial phase, delayed phase, and a surge phase. I'll work back in reverse order and just talk about the surge phase. This surge phase is what you probably have heard, what the CDC have done and public health officials have done, is that the concept is that when a facility has an outbreak of pulmonary symptoms, that we can create a volunteer workforce that can drop into a facility and to help the staff facility in terms of triaging, treating, and then testing patients and also staff and employees rather quickly, and so that we can provide some relief to the staff members within the facility. And so that would be our surge phase. That sounds incredibly sexy, and it sounds incredibly dangerous. It sounds really exciting, and I have many volunteers for the surge team. I have to tell you that I would love for us not to ever have to use it. And if we did a really good job at the initial and the delayed phase, our hope and goal is to never have to use it. The initial phase and the delayed phase is really where we are trying to concentrate our focus in. It's providing a lot of the education, providing a lot of the infection control expertise and infection control principles, and bringing that into the facility at this point in time. What we also want to do is to provide an infrastructure that facilities can rapidly test and rapidly isolate patients, so that they could get the results back, so that they can serve their PPE. As you all know, PPE is in shortage in many of our communities nationwide, and perhaps also worldwide as well. And so having that infrastructure is incredibly important and helpful. Okay. I will share with you, and it's a testing criteria from the University of Washington, and this is what we and public health experts within our state are doing at this point, is that we are only testing symptomatic patients. And so whether or not they have new onset of fever, new onset of cough, if they have a fever, or if they have body ache, for example. And so those are the symptoms that we're really looking for. They don't have to have all of those things, but one of those things is then that we would test for those individuals. Travel isn't so much a concern anymore, just because it's really community spread at this point. And so traveling to other parts of the world that may have cases, I think that is much less important at this point in time. And so for the most part, we are only testing people who are symptomatic. You and others on this phone call may have heard that there are asymptomatic people who are being tested, and that is being directed by public health officials and the CDC to get that testing done. They do that for various different reasons, and one of the reasons that they do that is for study, and so that they can see how the disease is spread. And so based upon that, we do know that there are asymptomatic people who are infected with the disease. Whether or not that they can actually spread the disease requires that they need to be able to actually spew their droplets. And so coughing, sneezing, so making droplets go into the community and go out into the environment and get onto surfaces is usually the way that this disease can be communicated. And so if they're asymptomatic, meaning that they're not coughing and they're not sneezing, although they might be an asymptomatic carrier, I'll call it as a carrier at this point, they might not be spreading the disease. just on a very private and very personal note, probably at the start of this, just because I practice in a very high risk environment, I have stopped exchanging kisses with my family is because of that reason, is that I just don't know, particularly if I'm asymptomatic. So, and I'll make sure that we have room for questions as well. This really just reiterates that as well, is that testing supplies and the laboratory are really limited due to capacity. Despite what you may hear on the news, is that we cannot test everybody just because of the capacity of testing. And so we're trying to prioritize for those patients and those employees and staff that serve a very important public safety occupation, such as law enforcement, firefighters, EMS, healthcare workers as well. And so we are truly, truly looking for people who are symptomatic within this scenario. One of the important things to recognize is that many of your facilities, if you practice in nursing homes already, may have these testing kits already. It's really nothing special in terms of the media. And so these are pictures of media samples that many of your facilities have already. What is special is that it needs to be processed in a laboratory that can run for COVID. But the media and the collection is very, very similar to how you would collect a flu swab, but it's not a nasal swab, but it needs to be a nasal pharyngeal swab. Before we go into the collection, just to mention about PPE is that when you do collect this, is that make sure that you are in contact and droplet precautions. A word of that is that the CDC is currently still on airborne precautions the last time that I checked, but the WHO, the World Health Organization, essentially the rest of the world, and also the University of Washington and many healthcare systems have also moved to that, is that this is droplet and contact precautions. And so what that means for droplet is that you need to have a surgical mask, you need to have eye protection, and then the contact is gown and glove. And so that is the basic requirement if you're going to interact with someone with pulmonary symptoms that may be concerning for COVID. So either a PUI, standing for a person under investigation, or someone who has active COVID. The times that you would need to do airborne, though, when you're doing N95s, is if you're actually working very closely with a patient in terms of the intensive care unit and they are intubated, for example, or they're using NEBs as well, because now at that point, if they're using NEDs, their droplets are being placed into the environment very differently versus a cough or a sneeze. And so many of our facilities, we have educated them in terms of trying to stop using NEDs and return to the use of meter-dosed inhalers. And so that is what we have been doing. And also, it's really good to know that, that there are policies out there to conserve PPE. We have, at the University of Washington, supported our nursing homes by helping them write a policy to do that. And this is actually pretty important, is that many facilities may not have this in place, and to have that in place is very helpful. One of the things that I would call out here is that each facility should maintain kind of a protocol and access to PPE. I just on-sited a facility just this morning, and they'd said that they were storing their PPE in a room and they thought that they had it all, they had enough, and then the director of nursing went into the PPE room and it was gone. And so it wasn't locked down, and so trying to keep it locked down, keeping a inventory of it is incredibly important. And so for you residents and also any medical directors are on the line, having a reference point of how much PPE is really a necessity. And what I mean by that is this: it doesn't help to know the number of surgical masks that you have, but how we're asking our partners to frame the discussion is, if you had 5 people who are on droplet and contact precautions, how much PPE do you have days on hand still? And so framing that as a reference point is very helpful rather than total number. is that it better frames the discussion. And so we're all talking from the same reference point, because having a raw number really is not very helpful at all. This is a protocol that is also on the public-facing page. It's very similar to a nasopharyngeal swab. The one thing that I would highlight is the number 6 here, is that you have to keep it in place for 2 to 3 seconds, rotate it completely around for 10 to 15 seconds. This isn't very comfortable at all, but it shouldn't be painful. But also it can elicit a cough response. So making sure that if you are performing this test, to be in the appropriate PPE like we had mentioned, but also to ask your resident or the patient to turn away in case they do cough as well. Okay, this is just to inform you that within the University of Washington, we have set up a virtual clinic where they can, patients and employees can get tested even though they are not a UW patient. And so you could get registered, you could get access to testing, and that's a virtual clinic where they will ask you to complete a survey. You could get registered then as a patient. If you qualify for testing, they can set you up with an appointment, but you have to be at a local neighborhood clinic for that. We also ask that many of our facilities start tracing, is that many of the staff workers and the staff members within these facilities work in different places. And so we ask that they kind of keep a tally of where their workers are going so that we could see if there are any outbreaks to start tracing as well. And so we're providing that support. One of the things that we have also recognized from and learned from Life Care of Kirkland is that patients can rapidly deteriorate where they need to be hospitalized. And so we are bringing this into our skilled nursing facilities, is that if you are testing for COVID, and if someone is a person under investigation, that we ask that these individuals get routine vitals and increased in their frequency. And so that we ask for vital signs to be checked. All current residents to get checked at least twice a day. Some facilities are doing much more frequently than that. But we leave that up to the discretion to the facility, but at least twice a day. But there are certain triggers actually. And so if a person is starting to have symptoms, that we increase the frequency of their checks. But then if they have, and we pay attention specifically to their oxygen saturations, learning from Life Care that what the clinicians there have noticed that is that if there is a 3% drop from their baseline oxygen saturations, that these patients who exhibit that sign have a tendency to acutely decompensate rather quickly in the next several hours. And so it's not only, it's abnormal where it's below 88, but it's going from 98 to 95 that it wouldn't even be, it wouldn't even, no one would bat an eye at that. But now that we know that if you're investigating someone for possible COVID, that 3% oxygen saturation is important. And so we recommend to all of our skilled nursing facility partners, if you're testing someone for COVID, this is what we want you to be looking for. If you notice that there's a 3% drop, then we want you to check every single hour at this point. We also established and work with the local governments. This is the DMCC. It's called the Disaster Medical Coordination Center. Within every single system and region that there is the DMCC, and what this essentially means is that in cases of a disaster, such as an earthquake, you can have many, many patients who need acute care and seeking ER assessments. And so this system is activated. What the system is supposed to do, and when it works really well, is that this then will redirect massive amounts of patients to local area hospitals and distribute them in an even fashion, so not any singular hospital or ER is overburdened at any given time. And so our protocol that we are rolling out to our nursing homes within our local community is that if you need to ship out 5 or greater residents at any single point in time, as a bolus of patients, is then to activate the DMCC. And there's a local number there that is from Harborview, actually. And so it just so happens that Harborview Medical Center acts as the DMCC for the this central district region, and the Good Sam also acts as one as well. And so this is a picture or a graph of all the DMCCs that are located in your specific regions. So for the North District, it's Everett, or Providence Everett. For the Northwest area, it's Harrison Medical Center, CHI. And for the West District, it's St. Peter's down in Olympia. And so Harborview and Good Sam serves as the DMCC for the Central District there. We also created the surge plan that I had already explained, and so I won't talk too much about this, and I hope that we never have to activate this at all. Okay, this is just an example of our checklist that we created when we on-site facilities, when we're going through and walking through their facilities to see what their infection control practices are and to walk them through the logistical framework. This is not on the public-facing website yet. And so if you do need this, or if you would like to have this, please contact either myself or Dr. Bennett or Amy Varell, and we will make sure that this is available to you if you would like to have it. There are some also the scenarios that I have often been asked now. Many of the directors of nursing have a direct line to me, and my cell phone is that they ask about their staff, and you might be getting those questions too as residents. And so the CDC actually has some guidelines in terms of exposure risk. One of the exposure risks that they highlight is indirect or low risk, and then the other one that they highlight is medium to high risk. And so what the indirect low risk is, essentially if you as an individual walked into a facility or a school or any other location where that there is a person under investigation, or that there is known COVID, even if you're just walking through, for example, this, and if you're asymptomatic, it's okay to return to work at that point, and then you monitor if you should develop symptoms. And if you're experiencing symptoms after you're in direct contact, is then do not return to work. Going with the same principles and the same line of thought is that if you're not coughing, if you're not sneezing, then you're not aerating these droplets into the environment and infecting people. And so that's for people who are at low risk and indirect contact. And then there's also then what we had talked about is the medium to high risk and really close contact. And what close contact is defined is if you are working with a patient that is with COVID-19 for a prolonged period of time. Close is defined as 2 meters or 6 feet. You're kind of caring for the patient, or you're sitting within a room and you're much, much closer. Or the other thing is you're having unprotected direct contact with infectious secretions or excretions of the patient. And what you can consider that too is like if you're living at home with someone who is COVID positive, right? And so if you have a loved one or a significant other who is COVID positive and you're not wearing PPE, which I think that most people aren't wearing PPE at home, that would fall under that same category. And so at UW Medicine, our employees who have close contact or suspect or a confirmed case of COVID, and you're not wearing PPE, then they are requested to report to employee health. And if they're asymptomatic, then it's okay to return to work until you become symptomatic. And so you're supposed to be checking your symptoms twice per day at that point. If any time if your symptoms emerge within 14 days, then you're not to come back to work at that point. And then also for patients who are COVID positive already, and so we know that they are COVID positive, when can you discontinue or stop precautions? And this is also on the public-facing website as well, at least in our acute care hospitals where they're not intubated and they're not in the intensive care unit. What we're doing is we're checking a nasopharyngeal swab on day number 7 or after 72 hours of symptom resolution. And so, for example, or whichever is longer. And so we're testing that initial time within the 7-day period or after 72 hours after their symptoms have resolved. If that first test is negative, we're retesting again within 24 hours. So the first and the second test need to be separated by 24 hours apart at least. And if that second test is negative, then you then are considered to have cleared the infection, and you're allowed to then discontinue the precautions. And this really is helpful then at that point in time to conserve PPE as well as just because there is a shortage. If either of those tests are positive, unfortunately though, then you need to repeat the nasopharyngeal testing within a 72-hour period, so 3 days, if the patient is still hospitalized. Okay, and this is just for patients who are intubated or in the ICU, which I will go ahead and skip. And Amy will send this slide deck out because hopefully you're not having to work with those patients acutely right now for many of you. Okay, and I will just kind of stop there. Yeah.
Thank you very much. Excuse me. Thank you very much, Dr. Ong. That was fantastic. You've done a lot of wonderful work with this, and I really appreciate you sharing that with us. Things are changing so rapidly, so it's nice to hear what's happening right at this moment. We have a few minutes for questions, and then we'll transition over to talking to our folks from the Area Agency on Aging. So we'll take a few questions, and then if there are more, we can do that at the end of the session. So if anyone has questions, you don't have to raise your hand. You don't have to type it in the chat box. You can just, you know, unmute yourself and go ahead and ask. And while you're doing that, if you could sign in for attendance, if you go to slido.com, slido.com, and enter code C039, we'll get your attendance, and then we'll also make sure we can directly email you the resources that we're talking about. Okay, I think there's a question from Dr. Braun.
Yeah, one of my residents was fine, had no symptoms at all, but was very reluctant to go to the skilled nursing facility and round in an educational fashion. And I guess I would put it as under an abundance of caution. And so while we're trying to kind of continue our teaching activities, my best understanding was she is okay to go ahead and attend the nursing home and take care of patients, but she was concerned that she might be asymptomatic and yet provide a vector. What would you kind of advice would you give in that setting?
Dr. Braun, I will defer to Dr. Bennett there, because I think that when you're talking about a trainee, that kind of falls along the ACGME. But then I could take that scenario and talk about kind of a coworker, but I'll let Dr. Bennett go first.
Okay, ACGME has kind of loosened up guidance as far as required rotations, and a lot of the boards, like the American Board of Internal Medicine, I know because I received the communications from them, have loosened up the requirements somewhat, just saying that they understand that things might be unusual, that some people might end up on quarantine. For our geriatric medicine fellows, I'll just tell you what we did because of where we are located, and since it started off as the epicenter of all of this, our geriatric medicine fellows are not currently going to the skilled nursing facilities for, you know, dual reasons. One, they could bring something in, but also I wanted to protect them given the lack of availability of appropriate PPE in all the scenarios where you might need it. So that's how we approached it here. It's not, you know, there's no one right answer, but just sharing what we've done. And I don't know if Carrie Rubenstein, Dr. Rubenstein is on, if she wanted to hear.
Yep, I'm right here. Can you guys hear me okay?
Yep.
Yeah, thanks, Thuan. Really amazing work that you're doing, and I just have so much respect for the effort that you put in and really thoughtful approach. So really appreciate it. I can speak to the question, and I've been working in the hospital this week, so I can speak to a couple things from that end. We have also, by virtue of actually two of our fellows being sick, had this natural transition to them not going to the nursing home. And so, but we are very quickly moving towards, almost 100% telehealth at the nursing home. And so, we already have a secure messaging, so text, that was set up way before this, which is we're using a ton of, and then a lot of telephone, and then we're thinking about ways to bring video into this, and some of the billing guidance from Medicare, will allow some billing and coding for these visits, which is really low on the priority now. But so we have pulled our trainees, including the residents that go once every other month. And we're trying to do as much as we haven't stopped caring for the patients, of course, but we're trying to do it in a different way. And that's exactly what's happening in our clinics as well. From the hospital perspective, the hospital SNF interface has been very complex. We had a patient come from the nursing home without any respiratory symptoms, came with limb ischemia and a new diagnosis of metastatic cancer, very quickly decided they didn't want treatment. So 2 days later, the plan was back to the nursing home with hospice. He transported back to the nursing home, had a temperature of 99.6, and was sent back to the hospital for concern of COVID. So these are the subplot stories that are pretty distressing. He came back to the nursing home and died pretty much alone, with all the COVID precautions around him, because we were hoping that maybe we could rule him out and get him back. And so, that's, I think, some of the real difficult decisions that are coming up, that aren't on the first line of, hospitalization, ICU, but more of the transitions in care.
Thank you for sharing all of that. Thuan, did you say that you also had something to add to that?
No, I think that just kind of working on a different scenario, just because you had answered the learner question already for Dr. Braun, is that very similar to what Carrie was talking about, Dr. Braun, is that we are trying to limit our risk of exposure, because we understand that we could ourselves be vectors. And so where it is possible, we are transitioning to telemedicine. There are some visits that are not possible. And so that's what, for those sites, then we do still go in. And when I say we, though, what I mean by that is that we're trying to limit it to one singular provider. Many of our providers in different types of systems go to numerous different facilities. And so we're trying to limit one provider, one facility, and so that the exposure risk is limited. And we're not only talking about the provider themselves, but for the residents and also the employees as well. Your scenario, if you were going to say that this was a colleague, a faculty member, an employee, if they are asymptomatic, though, that they should still be able to go to work, and making sure that the appropriate PPE was available. And so they're asymptomatic, we would not consider that these individuals are infected.
Thank you all very much. I really appreciate, and again, like Carrie said, thanks for all the work you've been doing. Appreciate it.
Any other questions right now before we move on? All right. That's a big screen you have in your room there, Dr. Braun. I can really see that. It's a good thing I brushed my hair. All right. We're going to transition to talking about older adults in the community specifically. As you know, every month on Project Echo Geriatrics, we are lucky enough to have panelists who are from 2 different area agencies on aging. One here in King County, which is Aging and Disability Services, and one in Southwest Washington at the Southwest Washington AAA. They are, as you know, and as you've heard over and over from me, the area agencies on aging are available in all areas of the country. They're funded by the Older Americans Act, and they really have multiple goals, but really the ultimate mission is to keep older adults supported and thriving in the community for as long as possible. And right now, because of the nature of COVID and how contagious it is and how we're trying to move towards social isolation, social distancing, this is leading to social isolation for older adults who may otherwise normally be in the community. There are assisted living facilities are stopping visitors, are moving dining services to people eating in their own rooms, and this is very isolating for folks. There are people in the community who rely on going to congregate meals to get their food, and that's a challenge to address. There are a lot of senior centers, all the senior centers around here are closed, and so normal activities are not available. So the Area Agency on Aging panelists are going to talk about their response to COVID and how they're meeting the needs of older adults in these unusual circumstances. So there are 3 panelists from the AAAs who are going to talk. I think I'll first go to Brianne down in Southwest Washington, if that's okay, and then we'll move it to Thuan here in King County.
Hi, I'm Brianne. I'm the primary care liaison from Agency on Aging and Disabilities of Southwest Washington. And there's a few things that we've been doing. First is that our doors are still open and we're still providing all of our basic services. So those would be things like in-home care services. We have contracting out with our home delivered meal providers, connecting folks with information when they call in, all of our basic services. We have suspended home visits for right now just to be cautious that we are not actively bringing infection into the home where folks are staying. And so our services have become a little bit more flexible just over the phone instead of our traditional home visits that we usually do. Some of the things that we are connecting folks with, and this is something that any of you could use as well, would be the Washington State Community Livings Connections site. And the URL for that I can put in my follow-up summary, but it is WashingtonCommunityLivingConnections.org. And on there, there is a search tool that people can use to find resources themselves that they're needing if they don't want to actually contact the AAA to do that. There's a lot of different resources on there. The AAAs are also offering support for family caregivers too. So we can do assessments with family caregivers who maybe are feeling more stress at this time because, maybe they used to have more ways to get out and, leave their loved one with somebody else to get some respite time for themselves. But now they're just in the house and they're caregiving 24/7, which can be really draining on them. So they can hook up with the AAA to be connected to an assessment for caregivers. It's called a T-Care assessment, where we assess kind of where they're at on their caregiving journey. Are they feeling overwhelmed, burdened, stressed out, depressed? And we can put different services in place for what they're experiencing. So for some folks, just being able to know that they have a lifeline out there, that they would have someone they could connect to talk about what's going on might be really helpful for them. We can also help connect caregivers to different support groups. I know in our area, they're kind of scrambling to figure out how to best support the folks in the support groups right now because they're not meeting in person. So we've reached out to them to see if they're able to provide any sort of telephonic support. And I did want to share a resource specifically for caregivers who are taking care of someone with Alzheimer's disease or related dementia, if they go to the Alzheimer's Association website, and the URL is really long, but if they just Google Alzheimer's Association and coronavirus, it'll pop up the first search result, the tips for dementia caregivers during this time. There's some really nice, helpful tips on there. The other thing I think is important to note is that congregate meal sites that the AAAs are affiliated with, those have all moved either to like a drive-through service or a delivery service. And from what I understand, home delivered meal providers may be able to connect, are isolating at home and they're food insecure, connect with a AAA to get the contact information for the local home delivered meal provider. In our area, I've also heard that our home delivered meal provider is trying to be like mobilize a volunteer force who can just do wellness check-in calls. So that might be something to check into in your area as well. And as far as that goes, I think that's about everything that's going on with us. We're continuing to receive phone calls and referrals. Things just look a little bit different in how we're actually delivering those services. So just be patient with us. Thank you.
Thank you so much for all you're doing with everything changing so rapidly, and thanks for sharing that with us. I'm gonna transition to Thuan.
I have a quick question. Kate. It's Carrie.
Yeah, sure.
And I'm sorry, I forgot your name. Who just presented?
It's Brianne.
Brianne, I wanted to offer myself or my fellows, if you had any community locations, caregiving sites, Alzheimer's Association, any of the connections that would benefit from connecting with a healthcare provider for any reason to get some information directly from a physician or other healthcare provider, or if you have other ways that you think, particularly fellows who might not be doing some other patient care for whatever reason. I have a fellow who's pregnant. Anyway, my question is, my ask is, please reach out and let us know if there's any ways we can help.
That is wonderful. I really appreciate you offering. We were actually just having a discussion about that yesterday, kind of thinking, you know, would it be helpful for specifically our home delivered meals provider in our area, that's Meals on Wheels people. One of our folks was going to call and check in to see if they could use volunteers that are, you know, nurses or medical professionals who could call and do some sort of wellness checks. But we haven't heard back from those meal providers yet. What I understand is that because so many people are so kind, is that they've been kind of inundated with new volunteers at the moment and are having to go through background checks for all of those folks. So there's just some other hurdles to go over. But if maybe Amy could send you my contact information, or she could get yours to me, I would love to connect with you more about this in the future to see if we could get something going, because I think that's a wonderful idea.
Good.
Great. All right, we'll have, I think we'll have a few minutes for questions at the end also. I'm gonna turn it over to Fong here in King County. If you have additional resources that Brianne hasn't already talked about that you wanted to share. Oh, I think you're muted, Fong. Yeah, I think you're still muted. We're not able to hear you. And what I'm gonna do while we're getting that audio sorted out, I'm gonna move it over to Mary Pat. Mary Pat O'Leary is a nurse and planner with King County Aging and Disability Services. Would you mind, Mary Pat, just talking a little bit about the local response and any additional things you wanted to share?
Not at all. Can you hear me okay?
Yes, we can. Thank you.
Okay, awesome. So we are working with Public Health King County and our counterparts, vigorously working on meals and looking at different ways. I've been working to develop a script for what should be asked. Can you hear me okay?
Yes.
Oh, okay, so I'm working on a script with King County Public Health. So what what they can ask prior to delivering the meals, and then what the drivers should do. The drivers don't have personal protective equipment. They're used to doing a lot of chatting and visiting. So there's a lot of information that needs to be shared with them. Housing providers for senior housing, a lot of them have closed their building hours. So those seniors don't have anybody to go to. So we're really trying to work with the housing providers and make sure that the older adults have the needs and meals that they need. And in that initial screening that we're doing, letting them know we're going to be delivering foods. It may be Meals on Wheels, but it might be a meal from a senior center. We're saying, are there other things that other items that you need? I did talk to public health today about whether or not there was enough supplies of thermometers. So if people are being asked to take their temperature, you know, is there a thermometer available? So that's another really important thing. Though the case managers for long-term care services and supports are able to do telephonic assessments, we have been asked by the state to do kind of that surge for people that need to get out of the hospital and get them on case management, sort of a fast track. However, for those that have skin issues, people that are at risk for skin breakdown or have had a previous issue of a pressure injury, our nurses are still expected to go out and do those assessments. So we're really trying to formulate the plans and make sure we're coordinating really closely with the county. I participate in Older Adult Task Force, Mary Snodgrass, the AARP, and a lot of other professionals are on those calls. So thank you, Carrie, for that. I will share that information with Mary Snodgrass. And I just can't thank everyone enough for everything that everyone is doing. Thank you so much.
Thank you, Mary Pat. And Fung put together this fantastic set of resources that we're going to send out to everyone. And I'm sorry that the audio isn't working, Fung. If you can hear us.
Can you hear me now?
I can hear you. Did you have a few things to add? I want to save a couple minutes for questions, but if you have a few things you wanted to add, that would be great.
Yeah, I think similar to what Brianne said, our community living connections for San Ong King County still remains the same, so nothing has changes. And the Washington Community Living Connection is another resource for our residents to submit a HIPAA compliant referral form through there as well. Or they can call our local CLC for sending referrals. I'm also open for, you know, just questions or wanted to troubleshoot about patients or case, so happy to work with that. Mary Pat did mention about, and Brianne mentioned about home delivered meals. Very similar to here in San Ong King County. Our senior center are closed, so the concrete meals will be picked up or delivered. And home delivered meals may be authorized by our case manager during COVID-19 emergency until further notice. So our case manager can authorize more than one meal per day.
That's wonderful. I'm glad that they're able to everything's able to shift so rapidly to support older adults. This is really fantastic to hear everyone working together and working so hard on this. It's great. One thing I've run into with my patients, those who live in assisted living who can't have visitors, who are isolated in their homes. I've had some patients who, a couple of patients whose family members have called because they can't visit, and particularly my patients with hearing impairment, they're feeling very isolated, and those with depression, it seems to be worsening right now because they're not able to interact with as many people. So I know you put some resources on there on what we're going to send out, but if there are any other thoughts folks have to address that for those who are isolated but in a congregate living situation.
Can I just make one other comment?
Sure.
What we're finding is that a lot of the senior centers are really concerned that their older adults who are no longer exercising. So I would just like to see if we can, as a ECHO, just kind of forecast this out and plan to check on folks who may have gone to regular exercise classes, but perhaps with inactivity are greater risk for fall.
Absolutely. Yeah, we definitely want to be checking in on our patients and our loved ones who are not able to go to those. Elizabeth, you unmuted.
I was just going to add briefly to your point about stress and depression, mood management. You know, there is evidence about outdoor light and the role of, you know, daylight. And so, you know, people can't go necessarily, they may not be physically able to go very far, but being outdoors in you know, the natural environment for even just, you know, I think it was 120 minutes a week is what I read is optimal, but it, you know, being outside each day can be helpful from the standpoint of stress reduction, and it doesn't have to be in long periods of time for it to improve. We're starting to do that regularly.
There are also services.
Can I have I've gotten a lot of questions and seen online about, is it okay for family to mail notes and letters and postcards to their loved ones that are in facilities?
I think right now that's an area of uncertainty. So a lot of people are moving to things that are, you know, like when they're sending notes to people in hospitals and skilled nursing facilities, they're trying to email things because we just don't know how much additional risk there might be from mailing things. Like the students who are off of school want to like make cards and things like that.
Yeah, I've heard a lot of people mobilizing that way, but that was my question, is whether, so they're not even delivering mail. So things should be electronic and FaceTiming, of course, or Zoom, or.
I believe mail is still being delivered, but whether or not that's a good idea, we don't know for sure, because we do know that COVID can live on surfaces. So it's unclear, and whether the risk would be the person at the end of it who is handing the mail to the person versus something that's prepared. So I think caution is a good idea.
Jump on top of that as well. Okay. Yeah. So yes, I think that mail would be reasonable, but there is some risk, and there's always risk with everything that you do. But I think that the important thing is the basic hand washing. And so if you touch any type of service, that then you wash your hands. And so, for example, if you're opening your mail, that then you wash your hands afterwards. And so those basic simple things is just think of services that of high touch surfaces, and a mail could definitely be thought of that if you're thinking about a facility, because now not only the person who wrote you the letter, your family member or your loved one, someone picked it up, it went into a processing center, that processing center sent it out, someone delivered it into the facility, someone in the facility sorted it out at that point. And so there's multiple touch points. And so I would consider that kind of a high surface or high item touch area. And so just making sure that when you do that, is that just to practice still that basic hand washing after, the limitation of touching your face and your eyes. And if you do, make sure that they're clean. So it's like practicing if you were putting on contacts, for example, you would clean your hands before you did that.
Sure. And Dr. Braun wrote in the chat that they have had dementia persons with dementia who are very concerned about the inability to receive visitors, and it's definitely a concern for everyone. Phone calls, FaceTime, any sort of video chat, making that available to folks as much as possible. Some people don't have that technology. Just providing some companionship from afar as much as possible is really important right now. There is something called the Friendship Line that is run out of California, but at least the last I checked, accepted calls from anywhere, and it's meant to help older adults who have depressive symptoms or are lonely and socially isolated, and they have people there who are trained who can take those phone calls and will chat with folks about, you know, day-to-day things and provide some companionship. And there are some other services like that. I don't know if the folks from the AAAs or Helena, the social worker with Senior Care Clinic, know of any others.
We have a lot of volunteers. This is very
Yep.
Pat, particularly that want to really do more of a coordinated effort to make sure that there's a warm voice line at the phone, and also we're trying to do that for the meal deliverer people, to have a smile, you know, make sure that, you know, you're not just dropping the food off, but that you're acknowledging.
You're cutting out a little bit, Mary Pat, but I appreciate what you're saying. We want to just, when we do have opportunities to interact, we should take advantage of making those as meaningful as possible and really providing some companionship. As mentioned before, the Alzheimer's Association has, you know, special information on the Alzheimer's Association website. And they also have a 24-hour call line that you can call in if you're trying to problem solve issues for those who are living with dementia, whether that's, you know, how to get folks companionship who are socially isolated without putting them in danger, or new behavioral issues that might come up as people are more isolated and their routine changes, which is such a big deal for people with cognitive impairment to have a change in routine. So I know we're at 1:33.
Kate, can I make one more quick
yeah.
plug? Just to the residents out there or the fellows that are listening, find a way to get a list of your patients, your primary care patients. Do whatever you can, whether it's a formal telephone visit or not, just a call. They will hear your voice, they will recognize you, and it will be very meaningful. And so just, I think I can't stress that enough. If you have the time, reach out to your patients and the people that know you.
Thanks so much. That's really an important point. If there are any other questions, I know we're over time, and certainly don't feel shy about going, because I know all of you have places to go, but if anyone had other questions that we didn't answer yet, we can stay on for a little bit longer. All right. I'm gonna, we have our evaluation survey up. You can point your smartphone camera, if you have one, at the QR code, or you can type in the URL, which is www.surveymonkey.com/r/Geri-Echo-survey, and fill out the survey afterward. And again, anyone who fills that out will make sure that that if your email address is in there, that we can link you to the resources. We'll send out a bunch of stuff. Feel free to pass on any questions that you have remaining, and we can get them to the right people to get those answered for you. And thanks for all the work that all of you are doing in each of your realms, and stay safe and healthy. And we'll see you next month.